So hello everyone and welcome to our latest webinar from the RSM. This is the 89th episode of the COVID-19 series, and my name's Andrew Jack from the Financial Times. It's a great pleasure to welcome so many of you here online over the next hour to discuss schools, infection and the impact on children. A reminder that we'd encourage you to post any questions or remarks in the Q&A function here that you're watching, and you can also upvote others' questions to help us prioritize which ones to answer. And we'll be wrapping up about 1:25 UK time. So we're here to discuss with Dr. Camilla Kingdon, who's president of the Royal College of Paediatrics and Child Health, with Professor Christina Pagel, Director of the Clinical Operations Research Unit at UCL, and with Leora Cruddas, the Chief Executive of the Confederation of School Trusts. And of course, a topical time, school not so long ago recommenced, of course, very much largely in person, vaccinations now being rolled out in secondary schools, and also, of course, a fresh surge to record levels in infections within children. So we'll talk today about some of the challenges around the epidemiology, around issues of vaccines, but also more practical issues in the classroom facing children, teachers, parents, and other staff, and the wider repercussions ongoing of COVID. Perhaps we might start, Camilla, with you and just a few reflections that you're seeing in terms of the key issues and challenges over the last few weeks with schools reopening.
Thank you very much, and it's a pleasure to be here today. So yes, this has been as a Royal College representing not just paediatricians, but also child health more broadly. I mean, we've been really focused on this topic in the last few weeks, particularly because of the issue of vaccination and the lively debate that's existed for the last couple of months around vaccinating, particularly the 12 to 15-year-olds. And as a college, we've been very involved in kind of informing the discussion and the debate around that, anticipating that this was going to become a very lively issue as children went back to school this term. The pandemic, fortunately, has impacted in terms of the direct impact of the virus on the health of children. Children directly in to a very minimal extent, and for that we ought to be very, very grateful, when we compare children to older members of the population. But what has perhaps been less well recognized, and for which we certainly as a Royal College of Paediatrics have been really keen to amplify the voice of, is the indirect effect of this virus on children and on their overall health and well-being. So that's very much been where we've kind of been putting our energy, how we've been advocating for children and young people. We work very closely with a large group of children and young people who here at the Royal College, and so really been in listening mode, trying to understand from them their lived experiences of what it's been like to be a young person during the pandemic, the consequences on their overall well-being and mental health. And I'm sure we'll talk a bit more about this shortly, but that's really been our focus of our attention for the last 18 months, but particularly more recently.
Thanks, Camilla, and we'll come back to a lot of those issues you raised. But Christina, just give us a little bit your perspective. I mean, how much in line with international practice is the situation in UK schools looking like, or how much are we an outlier?
Well, we're actually like a massive outlier internationally in Europe and really other high-income countries. So, and I have to say, I think it's because for some reason in the UK, high cases in children are just not seen as much of a problem. So most countries are either doing vaccination of teenagers, which they started over the summer in time for the new school year, or mitigations in schools. So like masks, ventilation, bubbles, or they have low community rates. They're keeping COVID low everywhere, in which case, schools are pretty fine. Most countries are doing at least 2 out of those 3 things, and we have been doing none of them. So we have by far the highest rates in children in Europe right now. And we are seeing in teenagers really, really high rates. So in England now, they're almost twice as high as they've ever been, which was the end of last July. Hospitalizations have been more hospitalizations in children since May than there were over the whole of the previous pandemic. And in other countries in Europe, which started vaccinating in the summer and have mitigations like masks in schools, we're seeing there's been no back to school spike at all in teenagers and under 15. So there is quite a big difference in just how we seem to be seeing infections in children.
And Leora, so we're going to talk here a lot, obviously, about the sort of the medical issues, but what's your take on the wider issues, including learning loss, mental health, stress, and so on both teachers and students?
Yeah, so thank you. I'd like to just start by reinforcing what Camilla said about the indirect impacts of the pandemic on children. So this is not just about educational disruption, although that is obviously also very, very significant, but also the health and well-being of children, young people, the social impacts, and indeed the economic impacts of COVID-19 on children and families. So I think, it's been a tragic time in our global history, and so many of us have suffered the unbearable loss of loved ones, so family members, relatives, friends, and colleagues. But I wanted to start just by talking about the brilliant response that we've seen from our public services, of course from our NHS, but also from our schools, that moved very, very rapidly to delivering education virtually while still keeping schools open for the children of key workers and those who most need our help. So feeding children, caring about their welfare. And when schools opened, I think, again, we saw a magnificent response to things that they'd really never been asked to do before. So they implemented public health systems of control. They set up COVID testing on school sites. They assessed children for gaps in learning. They supported those children who were returning to school, who might have experienced difficult circumstances in the pandemic. I think I'd like to just start this initial introduction by saying we carried out some research with the University of Nottingham, and I just want to quote quickly from that research to demonstrate, I suppose, the way that schools and trusts have responded. So this is from the research. Over the 12-month period of unanticipated disruption and discontinuities, schools and trusts have gone beyond coping and merely surviving. Their CEOs, their leaders, regardless of the size and geographical distribution of their schools, had demonstrated a strong sense of efficacy, agency, and robust resilience, a profound sense of care and agile, adaptive, values-led leadership, which had permeated their schools, minimizing disengagement of most of their pupils from learning and connecting closely with parental communities and external agencies. So although we have seen the impacts of the pandemic, I think that the school response is really noteworthy in England.
So Christina, a good response from schools, but nonetheless this big underlying burden of COVID. I mean, you said that the UK was something of an outlier, including with these record levels of hospitalizations of children. So Christina, what is your sense, should we be worried compared to the trends and the practices of schools in other countries? How heavy a burden with what implications specifically for children initially are we seeing?
I mean, yes, it's obviously true that children are much less affected by COVID than adults, but they are still affected. So about 1 in 200 children need hospital if they've had a positive test. We've had since the middle of May, so since Delta became prominent, and we've had no more mask wearing in secondary schools. Over 4,000 6 or 17-year-olds have been admitted to hospital, and that compares to just under 3,000 in the whole of the year before that. And children can get long COVID. I mean, there have now been lots of different studies. They all measure it differently. It's a really hard thing to measure, and they all kind of look at it slightly differently. But somehow, the ranges are somewhere between 2% to 15% of children seem to get symptoms that last longer than 3 months. The most common of which are tiredness and headaches. And even 2% is quite a lot of children when we have really high case rates. We've had over 100,000 10 to 14-year-olds infected just since the beginning of term. So even 2% of that is still several thousand children. So there are impacts, and those impacts aren't felt equally. We know that when it comes to admission to hospital, we know that when it comes to admission to ICU, particularly with the kind of the late onset pediatric inflammatory syndrome, that it's mostly children who are from deprived communities and minority ethnic communities who are affected, who are also more likely to be in families that are less vaccinated and also more likely to suffer from educational disruption. So it's a very unequal impact that we're seeing if you allow really high case rates in children.
And in terms of mortality?
So that is extremely low. I think up till March, there had been, I think, about 70 deaths of children with a positive test of COVID, but then later, directly due to COVID, it was maybe 30, and there's a population of maybe 12 million children. So it is very, very low. And the most dangerous thing is if you get the post-inflammatory syndrome a few weeks later, that comes with higher mortality. And as I said, that mostly, unfortunately, affects minority, ethnic and deprived children. But again, that is rare, much, much rarer than in adults. And I think there've been, maybe another 10, 15 deaths in children this summer, which is, but then I would say, well, the vaccination isn't associated with any deaths, and it can prevent that kind of severe outcome.
I'll come on to vaccination in a second, perhaps with Camilla, but first you and maybe Leora want to come in just on, so we've talked about the effect on children. So what about the effects in terms of the relative burden on teachers and school staff? What's the evidence of onward transmission and severe infection compared to other groups in the population? Christina, have you got anything to, any insights into that?
On the wider thing on teachers and parents?
Yes, as opposed to the children. How heavy is their relative burden compared to other adult sections of the population?
Yeah, so I mean, there've kind of been various conflicting studies on teachers, either showing that they it's the same as a community, and some showing that it's slightly higher. I don't actually know right now what the situation is with teachers, but we are seeing right now that the high cases in children does seem to be spilling over to their parents, in that the generation that has the highest growth rate after children of 40 to 59-year-olds who are most likely to be parents of teenagers. And in some of the hotspots, like there are some really like big hotspots, especially in the East Midlands. So Kettering had 6% of its 10 to 14-year-olds test positive in the last week, like just the last week. And their rates in their parents, 40 to 59-year-olds, are now higher than they've ever been in the pandemic, so higher than they were in winter. So we are seeing that there does seem to be this spillover to their parents. Whether that now goes up to their grandparents is kind of the next question, where we know people are more vulnerable. What we are seeing is actually in young adults and 50 to 60-year-olds, cases are still falling.
But there seems to be some evidence of sort of onward transmission with children as the vectors to teachers, and indeed back to their families, rather than the other way around.
Yeah, I mean, certainly, I don't see how you can explain that timing where cases go up in children and then go up in adults later. And cases are so much higher in children that I can't quite see how you can say that they're catching it from adults. It doesn't seem to make sense to me.
Yeah, and Leora, again, from your perspective, thinking particularly about teaching staff and other employees in schools, I mean, have we got the balance right at the moment? Do you think the return to school and the current policies for infection control are adequate?
So I'm probably not qualified to speak on the medical grounds. I'm an educator, so I can talk about the reality of the situation in schools, but I don't think I can comment on vectors in transmission. So certainly there is some impact on staff. Whether that's any more significant than the general adult population, I would need to be advised by my medical colleagues. I think schools, as I said in sort of my opening remarks, I think schools have been very responsive to the public health endorsed system of controls, and have consistently done what has been asked of them in relation to the system of controls. And I think that certainly did contribute to keeping infection low, in the return to schools. I mean, that was done with a very high level of vigilance. So I think what I'm most worried about is the impact on children's learning, the disruption to education, the regional variation that's been referenced, and sort of the wider social and emotional needs. I'd add one more thing. I think schools and trusts as employers have been very, very mindful of staff well-being, not just teacher well-being, but all staff. During both the lockdowns and the return to school, there's been a lot of attention paid to staff well-being, which is, I think, a really positive response from schools and trusts as employers.
So Camilla, let's talk a little bit more about the vaccination rollout into this younger age group. What's your judgment been about the wisdom of that decision, and then about the practicalities of its rollout?
So I think what's been really interesting as a paediatrician, and certainly as my role as president of the Royal College, is that I have had colleagues approach me from both ends of the spectrum. So that I've got colleagues who believed that we should have been vaccinating children many months ago, and I've got colleagues now who are extremely anxious about the rollout of the current offer of universal vaccination of 12 to 15-year-olds. So there is no doubt that there is a kind of a wide breadth of views about this topic. And so, when the chief medical officers approached us, as well as the Royal College of General Practice, the Faculty of Public Health, and the Royal College of Psychiatrists, and the Academy of Medical Royal Colleges as well, in fact, to help them form a view as to, in terms of their recommendation to government. We took that responsibility very seriously, and we convened a group of paediatricians, all in kind of elected roles within the college, to actually sit down and genuinely work through this, because you'll be aware that the Joint Committee on Vaccination and Immunisation had actually spent many, many weeks deliberating over this issue, using the evidence, but only very specifically focusing on the direct health benefits. And you'll probably be aware that they formed a view that there really was only a very marginal case to be made in favor of offering vaccination. And so the chief medical officers came to the kind of wider health community to say, give us a steer on how you as a group of professionals are sort of getting a sense from your clinical practice, from your interaction with your colleagues, about which way we should go with this. And so we spent a good chunk of time really considering the arguments for and against vaccination. And I know other countries have arrived at the decision much more quickly, but I think each country does have its own unique set of factors that make the decision-making process unique for that country. And I think for us as paediatricians, what we were seeing in our clinical practice was a very sizable rise in the number of children presenting with mental health conditions. Now, this has been patchy, and I think some of my colleagues on this call have kind of alluded to the geographical variation in terms of impact. And certainly with mental health, there were some parts of the country that had just seen a small uptick in referrals of mental health conditions, and others that were reporting 3-4 times the number of children presenting with significant mental health conditions. And certainly within our acute hospital pediatric services, we've been noticing more children needing admission because of severe levels of psychological distress. And that was not something we'd seen before. The children are resilient. The children of this country are extremely resilient when we think about what they've coped with over the last 18 to 20 months. But I think over time, the lack of certainty about whether school was or wasn't happening, they've watched their parents dealing with a whole gamut of their own stresses, and particularly in children living in areas of relative deprivation, where actually these issues have been even more central to their kind of day-to-day existence, we've seen a disproportionate impact there. And so those factors led us to form a view that we did think that there was some significant wider health benefits in terms of mental health, well-being, and of course, as Leora has talked about, the significant educational benefits, which are not just about what you learn in school today, but we know the importance of education in terms of lifelong health and well-being, is crucial too. So that was why, as a Royal College, we came to the view that offering children, the 12 to 15-year-olds, in terms of the universal offer, vaccination was part of the toolkit that we can use as a country to get children back to school and back into a kind of routine and a structure that we believe children and young people need for their health and well-being.
And what so far has been the feedback, as it were, from children, as far as you can understand, their reaction to the use of the vaccine and how it's perhaps their evolving perception of the pandemic?
So yeah, really, really important. So I mean, we work with a lot of children and young people, and we have specifically asked for their views. And actually, I think, to be honest, it's very similar to adults, in as much as children wish to have the choice. They wish to understand the risks and the benefits, and they want to have a proper conversation about that, so that they are part of that decision. But very much this issue of choice and being informed is key. So I don't think we're not getting signals that like all children are going to want it or all of them don't, but rather that, as with all of us, that actually for your individual circumstances, children are wanting to be part of that decision and have a conversation about it, which is why the kind of consent issues actually for this vaccine rollout are really key.
And Leora, have you had any feedback from the student population about how they're perceiving vaccination and also thinking about more generally the pandemic now?
So I think it's a little bit early to get a lot of feedback on the vaccination, because of course it's just being rolled out. But I would completely endorse what Camilla said about the importance of choice and being informed. I think those are absolutely crucial. In relation to the wider impacts of the pandemic, you'll probably be familiar with the work of the Office of the Children's Commissioner, Dame Rachel de Souza, who has conducted the largest survey of young people in England ever. I think she got 6% of children and young people, all children and young people, responding to that survey. And it's a huge data set and a very wide set of reflections, including about their experiences in the pandemic. But I mean, I think one of the things that's really important to say is that the vast majority of children are happy, and I think we need to avoid trapping our children and young people in a single narrative or a single story about their experiences in the pandemic. But there are a significant minority of children and young people, particularly adolescent girls, who are not that happy, and some of whom are, needing mental health support. And again, I would agree with Camilla that I think that is different regionally. But it's crucial now that we look through the spending review to fund a proper, comprehensive education recovery package. And my organisation has worked with other national organisations to set out a costed education recovery plan, which we have put to government through the spending review. And one of the things that we've said is that we need to bring forward the funding of mental health support teams. So mental health support teams are teams that would be in and around schools, providing crucial support for children, young people and families in this education or this recovery period, I guess. So I think that's an absolutely crucial plank of the way we need to be thinking about our response when hopefully in a post-pandemic period.
Yes, and Camilla, you talked about those mental health stresses that you were observing in children. Any thoughts to add there from your side about what best practice would look like in trying to cope with whether it's the direct and long COVID effects on children's mental health, or more generally, all of the stresses and disruptions and uncertainties that we've been talking about?
Well, not much more that I can add to what Leora has already said. I mean, I think if ever we've school nurses have shown, this pandemic has shown us the crucial role of school nurses. You know, I mean, I totally appreciate that teachers do huge amounts too, but I think, you know, school nurses have often been forgotten, and this pandemic has taught us about their kind of crucial role in everything from, you know, sort of safeguarding to the mental health surveillance. And just, you know, a whole host of important roles that school nurses play. And I think so, shining a light on the role of the school nurse, the value of the school nurse, and then thinking more broadly about mental health support. You know, I think this was brewing before the pandemic, but it's been accelerated in the last, you know, 18 months. And in a way, we need to use this as an opportunity to say, actually, this was probably coming our way anyway. We need better mental health support for children and young people. So let's learn the lessons and you know, see if we can think differently about how we structure the support we offer children, you know, more globally within the school setting, because it's a brilliant opportunity in terms of teaching lifelong skills to set children up to be healthy adults.
Okay, I'm going to open it up to questions in just one second, but very briefly, Christina, just giving your sort of global perspective. So we've talked about the differential around the policy on vaccination. More generally, are there other areas where you think we should be drawing lessons from practice and experiences in other countries around COVID mitigation, for example, you know, ventilation, use of face masks and so on? Are we outliers in other ways that perhaps are a cause for concern or an area for greater focus and research?
I mean, I think I already said it, you know, we're definitely an outlier in mitigations. We're one of the few countries that haven't got masks in secondary schools. Many have masks in primary schools too, and they're now starting to remove them now that they have case rates very low, so much lower than we have. I mean, I know, you know, Camilla did speak about vaccination. I just want to say that there may not be consensus in the UK, but there is consensus in literally every other high-income country that vaccination of teens brings benefit, and not just broader benefit, but direct clinical benefit. And you know, I'm an author on a paper that just came out in the Journal of the Royal Society of Medicine today, where we did a risk-benefit analysis here and showed direct clinical benefit. And JCVI's analysis, they just haven't published the details. I mean, it's impossible to know how they came up with their numbers, and I would really like to see it, because we find there's a lot of clinical benefit, as well as all the wider impacts on mental health and education, which is so important in children.
I mean, I was shifting to questions, and I see there is several actually about mask wearing. So would you argue, Christina, that actually we should move back to greater use, if not compulsory use of masks, at least while infection rates are high?
Absolutely. And I think the Centers for Disease Control in America just released a study last week showing that in schools that had mask mandates had 3 times lower rates of COVID than schools that didn't have mask mandates. They can't, you know, they're not 100% effective. You know, they can't control a pandemic on their own, but they can slow transmission. And currently, I think we want to do that, especially when we're seeing these really high rates in our teenagers, higher than they've ever been. And we're in the process of offering them protection from vaccination. Why don't we try and slow down infection as much as we can now and provide the vaccination that we're now offering?
Camilla, would you agree with that?
Well, I don't have any particular expertise with regards to masks. I mean, Christina's perspective is really interesting. I mean, talking amongst my pediatric colleagues, you know, we are currently seeing huge numbers of children with viral infections. There's absolutely no doubt about that. You know, probably more than we've ever seen at this time. In fact, definitely more than we've ever seen at this time of the year. And I think we're in for a very, very busy winter. But actually, you know, COVID is just one of numerous viruses at the moment. And in fact, in a hospital setting, it's a lesser player. We've got other viruses that are causing far more problems. So actually, amongst the kind of pediatric health community, we are not wanting to overplay the importance of COVID directly amongst children, because the fear of doing that is then that children's lives get disrupted again, and where we know that children are not significantly and seriously impacted health-wise by this infection, it's a difficult risk-benefit argument to make, and so I think mask wearing might actually have all sorts of benefits for all the viruses we're dealing with at the moment. So I don't have a problem with us discussing and thinking about masks, and I'm sure that Christina is correct in the way she's describing their impact, but in a way they're mitigating intervention for any viral infection, and so going into winter that might be something we want to discuss. But the feeling on the ground is that COVID-19, yes, it's clearly an important infection, and of course across the entire population, it's a crucial issue at the moment. But specifically amongst children at school, it is one of a number of viruses that are causing problems at the moment.
Leora, at least from the perspective, not necessarily from a medical perspective, but from what you're hearing from teachers, do you think there should be a case for compulsory mask wearing, whether it's for COVID or indeed other infectious disease prevention methods at the moment?
So I too am not an expert on masks, and therefore very much reliant on the public health advice. I think both Christina and Camilla's analysis is very interesting, particularly the perspective on the multiple viruses, and as we approach winter, whether that's something that should be considered. I think Camilla's right to talk about the risk-benefit analysis, and I think that the risks that, as I understand it, public health professionals have to weigh up is the educational considerations of mask wearing and masks in classrooms, so not in common areas, but masks in classrooms do pose a barrier particularly for some children with some types of disabilities to education. And obviously Camilla's talked about the importance of the continuity of education from a public health perspective. So that certainly plays into thinking about whether we do need a policy of mask wearing. So I think all of those conversations are live at the moment. But I would make a case that we do need to weigh up the risk-benefit analysis in relation to mask wearing. And of course, the policy framework does actually allow, the contingency framework does allow for a decision to be made within a local area, within a school, to move towards a contingency plan if there is an outbreak. So I think it's a little bit of a more complex conversation than should we wear masks or should we not wear masks. I think the balance of risk and evidence needs to be weighed really carefully.
So talking about the wider issues in mitigation, Camilla, there's a question here from Paul Clark. Why has the Royal College been so apparently reticent about calling for mitigations in schools in this new year?
Well, because we've seen over the last year, so on the premise that children are, in terms of the direct impact on their health by this virus, far less affected than adults. Accepting that point, the reason why we are saying that, for instance, let's have a conversation about the appropriateness of routine asymptomatic lateral flow testing, for instance, in children, is that we're wanting to get into a more kind of normal way of allowing children to go to school. And in a normal, so-called normal winter, the advice would be, if you as the child or the parent, your child's ill, they've got a fever, they've got a cough, they shouldn't come into school. But if your child is healthy, They should. And we're advocating for a conversation to say, how can we get back to that place where children can rely on going to school? Because I think part of the problem that we've been seeing is that it's this constant uncertainty about, will I go to school today and then find that we're all going to be sent home again? Will I feel fine, but I've got but I'm having to be tested twice a week, but I feel perfectly well. This is all playing into the kind of overall sort of elevated levels of anxiety amongst children. And so as a group of professionals, we're trying to say, what can we sensibly do and safely do to get back to a place where children can go to school when they feel well? So that's really the position that we've come from, and we're doing that from 18 months of understanding the virus and seeing that, in terms of direct risk to health, that actually the far greater risks actually are around mental health and the non-direct effects from this virus. So it's about recalibrating and thinking about the child specifically, rather than, I'm afraid, talking as a pediatrician, I am only talking about the child here, rather than applying adult rules to a child's environment.
Christina, do you want to come back on this as well?
Yeah, a few points. And that firstly, yes, of course, there are other respiratory viruses around, and some of them are worse for children than COVID. Masks would protect against all of that transmission. It's not like masks only work against one type of airborne virus. Secondly, regardless of other viruses, if you have a safe and highly effective vaccine like we do for COVID, then there's still benefit in vaccinating children against that disease, just as we vaccinate children against flu every year, and flu is less dangerous for children than COVID. So I can't quite see that the fact that there are other viruses has anything to say about whether we vaccinate children or not, or mitigate against spread in schools. We have so much data now that show that things like masks can work, and saying, we have to wait till there's an outbreak. There's literally an outbreak in pretty much every school right now. 1.4% of all 10 to 14-year-olds in England tested positive last week. That's a lot of children. So this kind of idea that we can just wait. We're still in a pandemic. We're still in a population now where children haven't been offered the protection of the vaccine yet. And I don't understand why we're so sanguine about the incredibly high cases that we're seeing that do disrupt education, that do disrupt people's lives, and are now spreading to their parents' generation. I can't quite understand that perspective, I have to say. Sorry.
Okay, we're going to shift to another question. Actually, I'll start perhaps with you, Christina. So it's around long COVID. You already touched on the instance, but Ian Harvey says, are the direct health effects as minor as some have claimed, given the scale of cases thus far identified?
Yeah, so again, there's no doubt that long COVID is rarer in children than it is in adults. But as I said, various estimates are somewhere between 2 to 14%. And the 14% comes from the biggest study, the CLOCK study, which is a national UK study in teenagers specifically. And in terms of the longer term impacts of COVID, we don't know yet. And I know that, Anthony Fauci, who's been advising the US government on COVID, has been very vocal about the fact that we don't know what the long-term impact is on children. And there are signs from studies in adults that there are some permanent changes to organ function and neurological long-term impact that we just don't understand yet. And that so far has been mainly in adults. But he's also raised the fact that this is really worrying. Like, what if there are issues in children down the line? Now, we don't know that, and hopefully there aren't. But why wouldn't you try and prevent cases now, just in case? So I think there's that kind of perspective as well.
And incidentally, this is perhaps slightly off your domain, but and obviously there's still a huge amount of uncertainty around it. But what do look to appear the most effective forms of intervention or support for those with long COVID?
I don't think we know yet. So there's no treatment for long COVID, and there's no diagnostic test. It's kind of a diagnosis by exclusion. So people who've had COVID that you either tested positive or in the early phase of the pandemic when there wasn't testing felt they had COVID, and then they kind of ruling out other things. And there's kind of a constellation of different types of symptoms that can kind of manifest that way. But the NHS has been really good setting up long COVID clinics, and they're now setting up specifically long COVID clinics for children as well. And the idea there is you really try and manage the symptoms and manage people's particularly fatigue, and then hopefully over time it resolves. And it does seem that for a lot of people it does resolve, but that might take several months.
Camilla, do you want to come back on that as well?
Yes, just briefly to say that there are 15 designated long COVID hubs that have come up, being developed nationally. And yeah, I mean, as Christina's mentioned, I mean, the issue is around the clarity of diagnosis. But certainly the way the system's been set up is it's being led by paediatricians, but really strong input from our therapies colleagues, so particularly physiotherapy, but other therapies as well. And I think it's fair to say we're feeling our way with how this is going to work. We don't quite understand the scale yet or the need nationally, but there are now facilities available, and referrals can be made to the appropriate local hub.
So there's a question here about transmission risks in primary schools, and what are the risks of them transmitting both between children and to staff and families, and what mitigation should be put in place in primary schools? Christina, did you want to come in?
Yeah, so transmission in young children is quite quite a contentious topic, in that there have been some studies that show that younger children are much less susceptible to COVID, and some that show they seem to be just as susceptible. And the issue is that they definitely do seem to have fewer symptoms. So you have many more that don't have any symptoms, and so they get tested less. But I think, so I guess my view of having kind of listened to the different arguments over time is that children probably do get COVID less, are less susceptible, and probably less infectious. But because of how they interact, especially young children, when you're in very close contact, especially with your family members, that then effectively overall they're just as likely to infect family members because of the types of contact that they have. And particularly if you don't have symptoms, you aren't obviously sick, and so you just act normally. And so in general, asymptomatic people, whether adults or children, can spread it very effectively just because they're out and about a lot and interacting with people without knowing that they're sick.
Leora, anything you want to add about practices or concerns you're hearing from primary schools?
So I think the attendance data is perhaps showing that there is more COVID-related pupil absence in both primary and secondary schools. There's certainly been an uptick in pupil-related absence, both at primary and at secondary. And obviously that is a live issue, and certainly my organisation is discussing that with the Department for Education and with public health colleagues about what the appropriate response to that is. So I just want to acknowledge, I think there is an issue.
Okay. Camilla, back to you. I think perhaps the question here about from Emma Weisblatt, a child psychiatrist, saying the best way to improve children's mental health is keep COVID rates low, keep families healthy, keep schools open. And given all the debate about mental health, essentially she's saying, should there have been a greater input from psychiatrists into the current debate around practices and approaches?
Well, I'm sure that's true. Certainly, when it came to the kind of discussion around advice for the rollout of the vaccination, the Royal College of Psychiatrists was very definitely involved. And I think hearing from our child and adolescent mental health colleagues, be it psychologists or psychiatrists, about what they're observing and the kind of the change in the kind of the number of cases they're seeing and the types of presentations they're seeing has been really, really valuable and important, because I think that kind of informs this kind of broader discussion around children and young people. Because I think it's, of course, across the last 18 months, the focus has very much been on the NHS, acute services, the ability for intensive care units, etc., around the country to cope with the demand. and so often the kind of the non-acute, or rather the non-acute physical presentations and impact of COVID has often been lost in the narrative and in the stories. And of course, with particular, I'm sure it's true of the whole population, but you know, I can only really speak about children. You know, the impact, this huge impact on children's mental health. I think the messaging has been so important to hear, because it's helped us inform that kind of bigger picture, that bigger understanding around the burden of the pandemic. And I think hearing that message clearly is also hopefully going to help us inform about how we recover from the pandemic, and thinking about services going forward, and the work that we need to do around, you know, clearly the kind of very severe mental health cases, but also the kind of lower level sort of reduction in well-being, increased levels of anxiety amongst children, etc. Just being aware of it. So, you know, it comes back to the previous comments about school nurses, and sort of thinking about some of those kind of preventative strategies, early intervention. I think that's got to be where our focus goes going forward, because these psychological consequences of the pandemic are going to be, you know, could have a generational impact if we aren't live to them and thinking about how we're going to tackle them very proactively.
And Leora, continuing on that theme of the wider stresses and fallout from the pandemic, and going back to your earlier points on face masks, I see there is a question here about what are the disadvantages of mask wearing for learning at home and missed social interaction, non-classroom activities, those effects on children, and particularly those with special educational needs. Leora.
So I think my point was about the impact of face masks on children in the classroom, and certainly not for all children. Of course, some children, the face mask is absolutely no barrier at all to education, but there are groups of children for whom it is a significant barrier. So, for example, children with hearing loss or a hearing impairment, who rely perhaps more on the face and also particularly the mouth to sort of communicate and to understand what is going on in a classroom. But there are other groups of children as well for whom face coverings, you know, can be an impediment to education in the classroom. And I'm not, just to be clear, I'm not making a case for not having face coverings in the classroom. Definitely not. I'm looking at what the education impediments are, so that a proportionate decision is made. And certainly if the risks to children of infection in the pandemic is more significant than the risks around access to education, then there should be a policy of face coverings in classrooms, as indeed there has been. So this is about understanding where those impediments are and putting in place, I think, reasonable arrangements in classrooms where we do have to have face coverings for those children for whom the face covering is a barrier, making reasonable adjustments for them so that we are mitigating the impacts of the face covering being a barrier to education. Okay.
Christina, perhaps there's a couple of questions here for you. One around the assumption about the size of droplets for transmission. Is it now accepted that smaller aerosols, those below 2 could be transmitting a lot further, and what are the implications for school classrooms?
So, I mean, I'm not an aerosols expert, but I think it is true that the fact that COVID is primarily spread through droplets and through aerosols, fine particles, and is an airborne disease is the consensus now. I mean, it is. And that means that, you know, early on in the pandemic, we were very concerned about the 2 meter distancing, and also very concerned about keeping surfaces clean. It now seems that transmission through surfaces is much rarer than we thought, and is definitely not the primary means of transmission. And it is through sharing air with people, really. And so that's why ventilation has become into much more prominence. So that's why the government, has got a policy of rolling out carbon dioxide monitors to schools. Now, what CO2 monitors do is they don't clean the air, but they can tell you if it looks as if you haven't refreshed the air enough. So what you're trying to do is refresh all of the air in a room about a few times an hour. And if you have the windows open at 2 points, so you kind of get a draft going through, that happens naturally. So what the plan is that if you can tell, okay, I need to keep the windows open, I need to open the door, maybe I need to empty the room for a little bit, that is a way of trying to make sure that you don't end up in a situation where you have lots of kind of COVID aerosols in a room. And then if you can't open windows, you can use what are called HEPA filters, which filtrate the air out and are often used in hospitals for that reason.
Okay, and there's a question here also about reports that teenage boys are more at risk. Actually, the question says from vaccines, although we might also just talk about more generally from COVID. Any evidence you're seeing around that? There was a report saying they're more exposed to heart problems after vaccination.
Yeah, so when it comes to heart inflammation after vaccination, which is the rare side effects, overall it's about 40 cases per million doses, so it is very rare, but it does happen more in young boys than young girls. So I think in young boys it's about 60 to 70 per million, and in young girls it's about 10 per million. So that does seem to be the case. Now what is coming out now is that now that some of the bigger countries like the US have been vaccinating teens for several months, it is looking as if all of those cases of heart inflammation are pretty mild and resolve quite quickly. And there's also been much more information now that actually COVID itself gives you a higher risk than the vaccination of heart inflammation. And that also seems to be more in men. And I mean, I'm not a clinician, so I don't know why that would be. So yes, it does seem that when it comes to heart inflammation, it does seem to affect boys more than girls, but that COVID is likelier to give it to you than the vaccine.
And this question here might be for you and Camilla. So on the level of risk for clinically vulnerable children under 12, where there's no mitigations in schools, how concerning is that, and what measures could be taken more? Christina, do you have a view?
On the clinically vulnerable children, so I mean, I think, you know, and JCVI did say this, that certainly clinically vulnerable children are at higher risk from COVID. I mean, as they are, I imagine, from other respiratory viruses. Certainly when you look at things like ICU admission, it's disproportionately children that have underlying health conditions. And there's no indication that they are at higher risk from the vaccine. So I think, you know, the case for vaccinating clinically vulnerable children is incredibly strong.
Yeah. Camilla, anything to add on that?
Yeah, I think that's right. You know, when we've various groups, both, you know, around the world, have kind of analysed their data, trying to understand, you know, which groups of children bear the greatest burden from COVID. I mean, the numbers are small, so I think we just need to keep emphasising the fact that the risk of complications from COVID, and certainly the risks of death from COVID in children, are extremely low. But when you really try and tease it out, there is no doubt that there are some groups that are more vulnerable than others. And so, in fact, the JCVI recommendation for the 2-dose regimen, which is for the children who are deemed to be at greater risk, there's now a list of children that would qualify for that, ranging from children with, you know, severe neurodisability to children with Down syndrome, to children with significant congenital heart disease, and so on. There's a list that that is available that would tell you whether your child does or doesn't qualify for the 2-dose at-risk vaccination program, as opposed to the single-dose universal offer of vaccine to 12 to 15 year olds.
So we're almost out of time. Very briefly, Camilla, there's a couple of questions here about whether revised symptom lists need to be updated or at least more widely disseminated, and specifically sometimes whether paediatricians aren't always picking up on long COVID symptoms. Is there more that needs to be done there for messaging or modifications to advice, do you think?
I think specifically when it comes to long COVID, you know, we've been very clear that we don't have a case definition. We are still discovering what exactly long COVID is in children, and so, you know, I think if we've got these 15 hubs, the people I know who are involved in running them are very kind of open to referrals, and are happy to. So I think if a family or a clinician believes they've got a patient or a child or whatever who has got long COVID, there is now a mechanism for getting them seen and assessed specifically for that. So, I'm not aware of any barriers to this, and I think we've. The fact that there's so much sort of uncertainty about exactly what it is and how it's going to pan out in the longer term has meant that we are very open-minded to seeing children and intervening as and when clinicians believe that's useful.
Leora, if you had one
therapy, yeah.
Okay, we've got to wrap up, but Leora, so just literally in a sentence, is there any sort of message you would put out now about practice that needs to change at the moment? Anything that's concerning you in trying to minimize the effects of COVID?
Yes, but I don't want that to be a COVID message. I want the message, my final message, to be this generation is distinctive for a number of reasons. Their resilience during the hardships of the past year, the way they've shouldered responsibility, the ambition for themselves and others, and their moral courage in standing up for the change they want to see in the world. Those are in fact not my words, but the words of the Children's Commissioner. And I think, just to repeat what I said earlier, I don't think we should trap our children in a single story, but rather we should listen to the next generation.
Christina, if you had one message of anything that needs to change or that people should be focusing on now, what would it be?
Well, I mean, my message is about COVID, and I think we need to put mitigations back in school, particularly masks in secondary schools now, and start rolling out the vaccine a bit more rapidly, and engaging with teenagers and answering their questions about it.
Camilla, a final word?
I think similarly to the last two, I think that my final word would come from our children and young people, which is all about saying they want to enter into the discussion, the dialogue. They want to understand the risks. They want to understand the benefits, potential benefits of vaccination. They want to be part of that choice. They see it as a child rights issue, and we would agree with that. So I think it's get children involved. But I don't think I can say it any better than Leora said it, which is around, a huge amount of praise and awe for the way in which children have dealt with the last 18 months.
Okay, so I'm afraid we're out of time. Thank you very much to Camilla, to Christina, and to Leora. Thank you all for watching and asking questions. Apologies we couldn't get through all of them, but I think we certainly tried to provide a very useful sort of update on the situation today. And just a reminder, the next episode of this COVID series with the RSM will be in 2 weeks' time on the 14th of October on diabetes. And then on the 28th of October, there's an interview with Richard Horton. So thank you all for participating. Thank you all to our panelists. Best wishes.